This video is presented by Interventional Radiology Medical Student Council. My name is Maggie Chung, and today we will be covering percutaneous femoral artery puncture. The common femoral artery is the most frequent access site for angiography. It is often favored for its size and ease of insertion. The common femoral artery pulse can be readily palpated in most patients. The underlying femoral head allows for easy compression. However, in patients with claudication, chronic arterial insufficiency, diminished or absent pulses, or bruits over the iliofemoral area, alternate entry sites should be considered. 3 key teaching points will be covered in this video. First, how to identify the proper entry site for femoral arterial access using anatomical landmarks. Second, the differences between single versus double wall puncture. And third, the procedure steps from incision to catheter insertion. To identify the puncture site, first locate the inguinal ligament, which connects the anterior superior spine and pubic tubercle. Remember that groin crease should not be used as a landmark to identify the puncture site, as it can be deceptive, especially in obese patients. The femoral artery passes under the inguinal ligament and can be located by its pulsation. Keep in mind that a femoral artery is bordered medially by the femoral vein and laterally by the femoral nerve. An entry site that is too low punctures the superficial femoral artery and may result in complications such as pseudoaneurysms and hematoma. An entry site that is too high may result in retroperitoneal bleeding because it is difficult to apply compression. The entry site should be over the middle or lower third of the femoral head, 1 to 2 finger breadths distal to the inguinal ligament. A metal instrument can be placed at the anticipated access site and viewed under fluoroscopy to view its location relative to the femoral head. After the surrounding area is shaved, sterilized, and anesthetized, palpate the femoral pulse with 1 finger above the entry site and 1 finger below. Hold the skin taut. Make an incision with a scalpel 1 to 2 centimeters below the intended entry site. Then gently dilate the skin incision by spreading. There are 2 techniques for needle insertion: double versus single wall puncture. In double wall puncture, the needle is firmly inserted until the underlying bone is encountered. The needle is then depressed a few degrees, making a more acute angle with the patient's thigh. The needle is withdrawn slowly until brisk pulsatile backflow appears. Compression is needed to prevent hematoma of the other wall. Single wall puncture should be done for anticoagulate patients to minimize risk of bleeding. Only the anterior wall is punctured. Here a single wall puncture is performed. Insert the needle at a 45-degree angle with the bevel facing up. Advance slowly through the skin and subcutaneous tissue. When you have reached the artery, you will feel a pulsatile sensation through the needle. Continue by applying firm but gentle pressure to the needle until you see pulsatile blood return. If you do not see brisk pulsatile blood return, it may be because the lumen of the needle is not in contact with the lumen of the artery. In this case, the needle should be withdrawn and pressure held. Once the needle is successfully inserted, advance the guide wire through the needle and into the artery. You should be able to advance the wire smoothly. If you feel resistance at any point, you should remove the wire and reconfirm flow through the needle, as resistance may be due to an arterial dissection. Once the guide wire is advanced through the artery, fix the wire with 1 hand and remove the needle. Insert the catheter sheath with dilator along the guide wire. Once the guide wire and dilator are removed, the catheter can be advanced through the catheter sheath. In summary, the entry site should be over the middle or lower third of the femoral head, 1 to 2 finger breadths below the inguinal ligament. Do not use a groin crease as a landmark. While a double wall puncture is less challenging to perform, compression is needed to prevent hematoma. A single wall puncture is ideal for anticoagulated patients. The proper procedure steps involve the following. After identifying the entry site, a small incision is made below the site and dilated. The needle is inserted and the guide wire is advanced through the needle. After removing the needle, the catheter sheath and dilator can be inserted over the guide wire. Finally, after the dilator and guide wire are removed, the catheter can be inserted.